I am Evan Shlofmitz, an interventional cardiology fellow at MedStar Washington Hospital Center here in Washington, D.C. And on behalf of Ron Waxman and CRTonline, welcome to the latest in our COVID-19 web series. Today we're going to be talking about COVID-19 and its impact on training and interventional cardiology fellowship. Joining me today, we have Gaurav from Northwell Health in Manhasset, New York, and we have Jay Mohan from Beaumont Health in Michigan. Thank you both for joining me.
Thank you for having us.
So to get started, Jay, why don't you tell us about what the impact has been for you in your program? Has redeployment been something that's been an issue for fellows, and what's been your role these past 2 months? And how's it been different from your regular role?
So, I mean, it's been a whirlwind the last 2 months. I remember going into March thinking, wow, I'm going to be able to tailor the rest of my fellowship to doing advanced procedures and, really worrying about doing the nitty gritty of interventional. And then, in the second week of March, basically right after the CRT conference, we got slammed in Southeast Michigan, and particularly at my hospital. I think we were the highest volume COVID center in Detroit at the time. And things really escalated quickly. We went from, I'm thinking myself as an interventional fellow, PGY7, I'm probably going to be one of the last people to kind of be deployed. But things changed not by the day or week, but almost by the hour. So we get an email at noon saying, the hospital's overrun, we're going to need help. Is anyone volunteering? And then the next hour, it would be, we need you to be redeployed right now. And what happened was the interventional fellows were actually the first ones to be redeployed because the people that needed the most help at the time were the critical care services. And there was only so many Palm Crit fellows and critical care attendings. And, if you really think about it, we are the closest to that group of individuals. We're very familiar with critically ill patients and dealing with placement of lines and dealing with hemodynamics and all that such. So the next day I was in the COVID unit. I remember the day before trying to just cram through vent management because I really had no clue. I totally forgot it. And what was awesome with social media, actually, I remember I posted something on Twitter and I got flooded with resources of, the quickest way to learn vent management. And, that first day was really observational for me. I watched how the team ran, and then I kind of really got into it the next couple of days. And what was really interesting was there was no experts in the field. You became an expert by just seeing the patients. And I think interventional cardiologists really brought a unique perspective to treatment of COVID because we're so familiar with treating the RV and hemodynamics, and, our patients are all hypercoagulable and clotting. So we're used to using high intensity heparin and things like that. So I think I brought a lot to the table with that. And it was cool to kind of grow every day with the team and figure out what would be the best strategy to improve our outcomes.
Yeah, it's such an important point you bring up because it's over the past 2 months, our understanding has changed, as you mentioned, sometimes by the hour, and oftentimes through just text message groups and Twitter and different publications where every single day we learn something new and completely changing our management. So it's been incredible from a historical standpoint, watching a new disease process unfold and the way that we manage it. So it's certainly been exciting. And have you, when you were redeployed to the unit, was it as a fellow or as an attending type of role, or a hybrid approach?
It was as a fellow. I had a critical care attending with me during my time, but some of my co-fellows, the actual general fellows, they function more as almost as a hospitalist. But one thing I will say my hospital did a really good job was they never left us on an island. We always had support. We always had attending backup and people to help us whenever we needed it. So I didn't feel like I was on my own at all.
Yeah, and that's an important, to have that support is critical during times like this. And as a Gaurav, I know Northwell probably has had the highest volume of patients anywhere in the country, if not the world. How's it been impacting you and your training?
Yeah, so I mean, I'll probably echo a lot of the same things that Dr. Mohan talked about. You know, it's sort of once we went into the mode of pretty much, you know, trying to expand our services or really repurpose our attendings and fellows, all sort of other interventional things fell by the wayside. So that was sort of mid-March. And, you know, as you just said, we had a very, very large influx of patients. And the whole key of it was how are we going to sort of expand? So we actually ended up expanding into 5 or 6 different units, or really repurposing like our recovery area, repurposing our short stay unit. And essentially it was all hands on deck. From our cardiology department, we essentially 72 physicians between North Shore and LIJ were deployed. So about 77% of total fellows and 80% of full-time faculty. We obviously kept the, you know, the first years, you know, with taking in-house call and 24-hour call, we kept them off of duties. And alluding to some of your other discussion points, we were deployed as a mix of hospitalists as well as critical care attendings. So I was deployed to a repurposed ICU, which was our cardiac recovery suite, which was repurposed to the ICU. And it was about 22 beds. And it was just me and another medicine trained hospitalist that was staffing that ICU. There was a pulmonary critical care attending that would come by, you know, for maybe 15, 20 minutes a day, sort of make their vent rounds. But otherwise, you know, it was all on us. And we did have NPs or PAs, depending on which unit you were, you know, whether it was NPs or PAs or mid-levels, and then some other units that were taking on more, you know, VV ECMO and a little bit more of this cardiac support, and bypass had residents and other fellows as ancillary staff as well. But yeah, I mean, in between March 15th to let's say April 27th, because we do have some data on that, our procedures pretty much dropped from, you know, in the 1,500 range for that time period to about 100 procedures cardiac cath-wise between North Shore and LIJ, which ends up being like 2 or 3 cases a day. And that's including PCIs, that's including everything. So it was only sort of, we divvied it out into a 4-tier system. Can you guys hear me okay? It says internet unstable.
Okay. Perfect. I hear you clearly.
Okay, good. So obviously we only did emergent stuff, and all that was in essence to you know, repurpose staff and repurpose you know, resources and make sure that we were fully stocked to handle the situation.
Yeah, and it's been a tremendous drop in procedures. You know, down here in DC, we weren't hit nearly as badly as places such as New York, but our volume in the cath lab has significantly decreased. It's starting to increase, but nowhere near levels of pre-COVID, nor have we started elective procedures yet. Have either of you began elective procedures yet in the cath lab?
We recently just did. We started off with TAVRs being started doing them because actually, you know, our AS patients, as much as people want to consider it an elective procedure, it's really not. And, you know, we're having some adverse outcomes from waiting. So we started doing our TAVRs about maybe 10 days ago, restarting like very high volume with that. And then we are still kind of skeptical about the elective procedures, but we are doing more outpatient high-risk nuclear tests and, you know, persistent symptoms, critical limb ischemia. So we're still doing that, but the volume is still really low. We have 5 interventional fellows at our program, and we're only scheduled to be in the main hospital's lab 2 days a week. So that's 3 days a week where you're not doing any procedures unless you're, I come to another hospital often to try to keep up my volume. But a lot of the other guys, they're those 2 days, if you get only 2 cases, that's all you get,
Right.
The only good thing I will say is most of the cases are all, NSTEMIs and, urgent cases. So they're all usually PCIs. So that's good. So that keeps us going. But it's still a huge volume drop, huge. And I'm wondering when it's going to pick up, because the thing is, it's not just the hospital policy. It's that patients are scared to go to the doctor and get evaluated. And, I don't know how long that's going to be. And I think that it's going to take a long time for volume to get back to where it was.
Yeah, definitely. I think it's been a very challenging thing educating patients not to ignore their symptoms. And understandably, I think we all went through the fear. The first days you're walking to the hospital with corona, not knowing what to expect and how to properly protect yourself. So it's understandable patients are staying home out of fear, but it's critical educating them that they need to seek care when appropriate. And we've been seeing an increase in late presentation MI, unfortunately.
Right. We've been seeing, that's been the majority of our cases here for the last week or so, late presentations, even last week, or, multi-vessel disease that, we're actually getting, CT surgery opinion on, just because people sort of waited. And, now it's at the point that it's probably mostly surgical disease, either that or sort of subtotaled vessels that probably closed up sometime in the last month or so. But absolutely right. We're just educating all our patients and telling them that, at this point, given our cath lab, we've sort of stepped up a lot of protocols to test people very aggressively, make sure they have a COVID negative test within 48 hours to the procedure, make sure they're aggressively screened. And even in New York State, it's actually 72 hours, but Northwell here is sort of 48 hours. And to some of the interventionalists, it's sort of like, well, if I stress my patient, it's high risk the next day, then I'm scheduling it for the day after that, then I have to swab them again. It could be a little bit of a hassle, but I think honestly, it's the right thing to do, to be very aggressive about testing, because that's the only way to ensure that other patients are going to seek the care when they need to.
Can I ask you guys a question? We've been seeing a lot of multi-vessel disease coming in also. Do you find that patients are more reluctant to have cardiac surgery? I've had a couple of patients say, there's no way I'm going to stay in the hospital for cardiac surgery. You either discharge me or, I want PCI. Have you guys run into that?
Yeah, absolutely. It's been definitely patients in scenarios where we would otherwise be pushing cardiac surgery, I think more aggressively, we're certainly going down the PCI pathway, mostly out of patient preference for exactly the reasons you said. And even in same-day discharge, there's the patients that we'd always have same-day discharge for, but there's a whole new subset of patients that, unless there's a true clinical indication for the patient staying overnight, we're doing everything we can to get them home. And that may be one of the secondary benefits from this whole thing. COVID is going to change our practice forever, I think. And there's things that we're going to learn from this that are going to stay with us. And hopefully some things will return to a normal, but some of the things that will become a new normal, I think, is our push towards same-day discharge whenever it's safe. And that's been something the field has been pushing for years, but never reached the numbers that it could. And I think all of us are realizing that that more and more often we can. I certainly think telemedicine, that this is revolutionized telemedicine, online webinars and online education, such as the ability to host Zoom conferences, have been introduced. So there are some sort of positive introductions of technology and changes in practice that I think will come out of this. As with anything, it's the innovation as a result of a new reality. So what clearly volume has been down the past few months. It's not the way we envisioned our last few months of the last fellowship, the last training before becoming an attending. What sort of resources have you been using to make sure you are prepared come July 1st?
Me personally, I've been using, I was really awesome what Sky did this year, being able to put all their lectures on demand. I've actually just been watching them. TCT did the same thing. That's been really helpful. I'm always big on social media, so it's been like, even more useful now because just the amount of repetition and sharing of cases is very important. One of the things our program did was usually for interventional conference, the fellows present the case and like we go over an intervention we did. But our chief of cardiology, Dr. Dixon, actually did a nice way of where he presented some of his old cases. And he'd ask me, Jay, what bifurcation strategy would you pick? What stent would you pick? What's your wire escalation strategy? And those are attending questions that you have to make in a couple months. And I thought that was super useful because I can make a mistake virtually and there's no harm to the patient, but I can see what his thought process is with everything. And I can also see what my other co-fellows, what they're thinking. So I think that's been a great resource. And then like what you said, Zoom has been huge. So all the lectures are recorded. We can access them at any time. I've actually had a lot of downtime to get some research done and also, study for boards so that this summer, I can focus more on, getting ready for my job. But one thing I will say that I wish we could get was, you don't get as much interaction with all your attendings. So you don't get to ask those questions like, what should I do when I start day one? Like, what cases should I avoid? What are the mistakes you made as an attending? Like these real questions, not clinical, but stuff that's going to help you on day one that we're kind of missing out, I think, on.
Yeah, no, definitely. And I think part of that was the motivation recently. Dr. Waxman had announced they're introducing a virtual fellows course that's going to be starting at the end of this month and hosted weekly for the next few weeks, going over complications and management of complications. Because I think that's we're all going to encounter complications at some point. And the biggest question is your comfort in managing it to make sure that any negative effects are minimized. But yeah, as you said, the on-demand online resources are terrific. I'm a big fan of the education you put out on social media. If you want to tell everyone your website, your info, it's been very helpful, I think, to everyone.
Yeah, I have an Instagram page, Cardiology on Call, and then Twitter is just at Dr. J Mohan. But the only reason I did that was because I was studying for echo boards as a second year, and it's such a minutia test. You got to know everything, and I thought the best way for me to know it was to be able to teach it. So that's actually how I started doing it, and then it just became kind of fun. As much as I'm a big cardio nerd. I really am. I just love it. I love sharing cases, and the cool thing about what we do is there's not one way to do everything. And I love the feedback that you get on Twitter from some of these big names. Like they ask you really tough questions, and as a fellow, it's cool to have interaction with those people. And it's also very rewarding to kind of teach people things. And I wish as a med student, I got to see this stuff. This stuff wasn't around. I still would have went to cardiology no matter what, but this is just like a crazy door opening for everybody to see the world of cardiology, and even our patients to learn more about what's going on.
Yeah, no, it's endless education. It's not just at the formal scientific sessions for societies. You're able to learn really all the time and bring it in. Even in the cath lab, sometimes downtime in between cases. You could get the bits of 2-minute bursts of information. So it certainly has changed practice. So,
yeah, no, Twitter is huge for that, and I mean, major kudos to you. And everyone on Twitter. That's one of my primary sources. But in addition to the resources you guys were talking about, I think other people like, Dr. Manas Berlakis, the CCC videos, from Sinai, and I mean, those are pretty much two of the top resources that I use, just going through multiple cases and just sort of going through what my strategy would be, because I think that's the little bit of area that we sort of miss out on, that sort of cognitive piece towards the end of the interventional year, where you sort of built up the muscle memory, you sort of have that, and now you're trying to plan your strategy, and what are you going to do if this goes wrong. So I think it's on us to really push our attendings and push everyone to sort of really cram that in towards the end of the year, and that's sort of something that we've started doing as well. So I think we'll be okay ultimately, because we do have a lot of resources, we have a lot of mentors, and people love to share their cases, love to teach. So I think the IC community has been really great during this time period, and I think we'll rebound from it.
What's the way you guys are using the resources? Because right now it's almost like there's so much stuff, and you kind of got to prioritize what you do. What I've been doing is like, maybe I have like a tough ROTA case, or use Guidezilla, and I'll look up a case similar, and it kind of reinforces. What do you guys do with all the resources in your training?
Yeah, honestly.
Yep, no, exactly.
Oh, sorry. Go for it. Sorry.
Go, Gaurav, go.
No, exactly what you just said. If I have a rough case on a specific focus that I want, whether that's a high risk PCI, or this morning we had a really tortuous case, and I sort of went through videos on how to deal with tortuous lesions. And I actually went to another resource, was ACC SAP, the interventional section of ACC SAP, where they do have like very tailored videos. So yeah, I'll probably do like a didactic session, and then I'll actually look up a case as well. Usually they have the cases within the videos, but I'll usually do like a didactic session from ACC SAP or from any one of these resources, and then I'll do a case that's fully dedicated to that, just to sort of reinforce it afterwards. But yes, it's very much tailored the way you were saying.
Yeah, there's so many online resources where you could look up something as closely to the case that you have, especially with these complex stage cases where you kind of know what to expect, what equipment you're going to be using, and you can see how other experts approached it, and what worked, what didn't work. And like anything else, just like you're learning from multiple attendings, you take all the information that you can and then make it your own. I want to thank you both. I know how busy it is as an interventional cardiology fellow, and thank you for your time and all the work during this COVID pandemic, and best of luck as you start your next stage of your career, and hopefully we'll return to in-person conferences at some point in the near future, and I'll see you at one of the cardiology meetings sometime soon.
Absolutely. It's been awesome to be able to talk to you guys and connect with so many people that this pandemic kind of grouped a lot of cardiology fellows together, and we kind of did it together, so it's been awesome.
Absolutely. Thanks, Evan, for putting this together, and thanks to Dr. Waxman as well, even though he got held up. But yeah, no, thank you. It was great.
Yep, I hope to talk to you soon. Take care.
Yep. You too. Bye now.